Assalamu alaikum and good evening. Welcome to another episode of Health is Wealth. I am your host, Shabnam Riaz. How are you on this Saturday evening? I hope you're having a great start to the weekend. And the weather right now across the country is, pretty cold, and soon it's going to be spring. So this is a sort of time of the year that you can really enjoy. Today, as usual, we're trying to bring to you a subject that is highly informative. We have many myths according to, health and precautions, preventions and treatment diagnosis. Today we're going to talk about minimally invasive neurosurgery, exactly what that is, what a neurosurgeon does, what a minimally invasive neurosurgeon deals with, and when you actually need to see a neurosurgeon. So for all that, we're very happy to have with us today in the studios Dr. Akbar Ali Khan, who is a minimally invasive consultant neurosurgeon from Shifa International. Thank you very much, Dr. Akbar Ali, for joining us here today.
Many thanks for inviting me.
Likewise. Okay, many times when we talk about neurosurgeon and neurologist, people are confused as to the difference and when to see the neurosurgeon or the neurologist. Can you sort of explain that to us?
Yes, it's very interesting. Since I've come to Pakistan, I do tend to see patients which are, for example, should be seen by a neurologist. And the difference between a neurosurgeon and a neurologist is that anything like that requires surgery is seen by a neurosurgeon. Anything that does not require surgery and can be treated with medical management,
right.
That means medications and that sort of thing, is seen by a neurologist.
Okay.
Now, for example, I can give you an example of that, like fits or seizures or mirgi is whatever it's called.
Right.
There are different types of it. One of them could be caused by a brain tumor, for example, and the rest could be caused by various other things that you cannot treat with a surgery.
Okay.
So that goes to a
Neurologist. Okay.
And the surgeon deals with the one that needs surgery.
Okay. Right.
And there are patients that I see that have gone for a surgical problem to a neurologist all around, and then they finally come to a surgeon. Then I see them, and then when I go through their notes, they've gone and seen neurologists and have been getting treated by neurologists for a while before they come to me for a surgical problem. So I think that is something which will take time for people to understand.
And neurology is the study of the brain and the spinal cord, you were telling me.
It's the same thing.
Right.
Like it's the same brain and spinal cord.
Right.
But there are surgical problems in that, and then there are non-surgical problems.
Right.
So, for example, if you get meningitis is an example. Now that is treated by a general medical doctor or a neurologist with antibiotics.
Right.
You don't need a surgeon to get involved in that.
Right.
But there are things that can cause
complications.
No, if something happens, the brain pressures are rising or something is happening, or you have a brain tumor or something, and then you have to intervene, then a surgeon is
His
required.
expertise is needed.
Yes.
Okay. All right. What about minimally invasive? Now that's a mouthful. What does it exactly mean?
Yeah, well, you're right. It is a mouthful, and it is very important to explain because minimally invasive neurosurgery is something which is what I do. Okay.
Yeah.
And it involves doing the same surgery that we are doing, neurosurgery, but doing it via a very different approach. It's called as a keyhole approach. So if you can enter a room without opening the door through a keyhole,
right,
why would you open the whole door?
Right.
So the way I do it, for example, is on the brain I do endoscopic surgery, which is like essentially a camera at the end of a stick. So I put that and take brain tumors out.
Okay.
Sometimes through a small cut on the head, sometimes through the nose without even putting a cut. And that's minimally invasive neurosurgery. And in the spine, I do the same thing. So I can, like, for example, fix a fracture without making a big cut on the spine, and that's called percutaneous spinal surgery.
Right.
So, and this is something I've already started here at Shifa International.
Okay.
And is on offer.
Okay, right. And then, of course, you know, as you said, that because this will be something that you're approaching in a you know, minimally invasive way. So then the recovery time is, of course, much quicker.
The main thing is, it's not that I'm doing all this to because you're different or this and that. This is, the world is moving towards that way, because I was trained, for example, outside. I've trained in US, in spinal surgery, in cranial surgery. I was trained in London. And the world is moving towards that. So actually there are centers being set up around the world, which are different to neurosurgery. They're called minimally invasive neurosurgery centers. Okay? Especially in the US actually, and Australia as well. And London is moving towards that. And minimally invasive, why we do minimally invasive? If I make if I fix a fracture, instead of putting a 12-inch incision, if I've done it through 4 tiny 5 millimeter incisions, patient can stand up the same day.
Wow, fantastic.
And go home the same day.
Fantastic.
And if I do a back surgery, minimally invasive, they go home the same day anyway.
Right.
The way I do it. And same with cranial. Obviously, you have to keep them for a little while to make sure there's nothing else going on. But if they've got a smaller incision, they recover well. And pain is less, patient satisfaction.
Right.
And this is what our aim is.
Right.
To improve patient satisfaction, reduce patient pain, improve outcomes, visualization is better. So this is something which is gradually, it's a win-win situation. But obviously the learning curve is long, so you have to be trained in it properly to do it. And then I think the world is moving towards that, because everybody is going towards minimally invasive. And that's why I'm here.
Okay. We find lots of people, you know, when they talk about back issues of the back and their advised surgery, they will be really reluctant to undergo surgery for an issue of the back, and you'll see that they'll, you know, be, you know, either going to Hakims or other things, and you know, they were doing that, a lot of that, because there seems to be a myth that people, you know, circulate a lot that, oh God, if you have surgery on your back, it could have devastating consequences. You might never be able to walk again. I've heard people say that. Can you dispel some of those myths, please? For us?
So I'll tell you, surgery for back issues, there are 2 different types of back issues that I deal with. One is back pain, severe back pain, and the other one is pain going down the legs, or you gradually, sciatica, or your spinal stenosis is another condition we call as, especially in the later age, that people are finding it difficult to walk. They can't feel their legs, or their legs feel very tight. And surgery tends to be offered, like surgery is the last step in the whole, because it's, if you see a neurosurgeon, I don't think any neurosurgeon will go and say certainly have surgery on that. There is a conservative part, which we call as conservative management, which does include medication, it includes intensive physiotherapy, different types of physiotherapies, stretching exercise and all that. And once all that has failed, and you've seen that surgeon for a certain number of times, and the surgeon has seen that you failed all that, and a surgeon offers you surgery, then I think it's a time to go for surgery. And the myths about it, that okay, you'll be paralyzed and this and that. I mean, I've been operating, I've done thousands of back surgeries, okay, and there are risks involved in it, obviously. But the chance of anything going wrong seriously in expert or experienced hands is less than 1%. So the example that I give to my patients, for example, since I've started in Pakistan, is that if you're going on a motorway, okay, if I tell you you want to go to Lahore, there is something very important, you'll say, yes, I'll go to Lahore on a motorway. But then if I tell you that, okay, there's a 1% chance you can have a car accident on the motorway, will you not go to Lahore? They all say, yes, we'll go to Lahore. So it's the same with lumbar surgery. There are myths around it. I do see people say that. And maybe if you go to inexperienced hands and those who are not, then it's a different situation. But generally, the risks are less than 1%. But it all depends on the patient selection and whether they've gone through a full conservative route or not.
So who's treating you is very, very important there.
It's very important.
Yeah, right. Okay. So let's talk about, you know, we'll come back to brain tumours and we'll talk about that. But now that we're talking about backache between men and women, and ages as well, and also posture. How much of a role that plays?
So I think it's backache is very common. Okay, it's a very common condition, and they do tend to come to me as well somehow, to a neurosurgeon directly. Backache is, general backache is treated by mainly general physicians.
Okay.
Okay, and obviously because there's nothing much going on there mechanically that I need to fix. Even if there is something going on mechanically, you need to go physiotherapy. Okay.
Okay.
Physiotherapy is the route,
Right.
which is very important. Obviously, medications for a short while, and then physiotherapy. And I tend to deal the same way my patients currently that I'm dealing with here as well. Between male and female, yes, it seems to be somehow more common in female, the one that ends up with a surgical option, because
Why
the
is
vertebrae can slip. And it's to
Okay.
do with pregnancies as well, and
Right.
the physiology is slightly different.
Okay.
But it can happen. And that one vertebra tends to slip on the other one. But then that needs to be sorted sooner. But what I see in Pakistan, the presentation tends to be very late. So it has slipped so far that correction carries more risk.
Okay.
But you still have to do it. But,
Right.
and also posture. Posture is a key. Okay? So if you haven't looked after your back for 30 years, 40 years or 50 years, and then you suddenly want me to give you a new back, that's asking too much.
Right. Right. Okay.
So you
So
have...
how are we damaging our backs?
So if you are not sitting correctly,
Okay.
if you are lifting heavy weights without proper precautions, okay, like you have to lift weight in a way that your spine is vertical, that's the key.
And bend your knees.
And bend your knees, yeah, that's the key. So avoidance is the key in back pain, okay?
Right,
So
right.
back pain is self-inflicted problem.
Right.
And you can fix that yourself from beginning. And I guess this is the idea of this program. So tell you that you won't have a backache if you listen
If
to
you're
this.
careful.
If you are
Right,
careful, okay?
right.
And
What about
like,
lifestyles, obesity? What about
yeah,
that?
so they all tend to affect back. So all lifestyles, everything that you do, obesity is not good for, everybody knows that. It's
Yeah.
worse for back pain as well at the same time.
Yeah.
Gentle exercise, especially even if you run, like even exercise needs to be done in an appropriate manner. So soft ground running is much better than running on hard ground.
Right.
So if you're like a athletic type person, so you'll have problems back pain if you keep on running on the road all the time.
Okay.
So soft ground
A
is
soft surface
Soft
will-
surface is better.
Okay.
So these are the things like you need to look after your back from the beginning so that you don't have any back problems later
Right.
on. And
Sitting down for long periods?
sitting down for long periods is definitely not good. But sitting down a long period, if you're especially sitting like days, so your posture is bad, you don't have any lumbar support. Like you have a lumbar support at present, which is good in this chair.
Right.
So they tend to improve your posture. You need to maintain your back in an angle that it is.
Right.
So then in the long term, you won't get any problems.
Right. Okay. So these are this is the advice that Dr. Ali is giving us, that you have to be mindful about your back and looking after it. No lifting heavy objects until you lift them properly. Your posture as well, your lifestyle, and gaining weight. These are all those things that if you do not look after your back, any part of your body, it's going to then ask for payback, basically.
Yes.
So that's what you want to do. Okay. When do you need to have surgery then?
Oh, that's a very difficult, every patient is an individual patient, so you work around that patient and then come to it. But if there comes a situation that you're developing neurological problem, that is your legs are getting weaker, you can't walk far, or you're getting a pain down the leg, for example, sciatica, which you mentioned, which is like a toothache, okay? So then I think if a surgeon recommends surgery, then I think you need to get it done sooner rather than later. Because the longer you wait, once a nerve
It'll
is
get
damaged,
worse. Okay.
once a nerve is damaged, I cannot fix that.
Oh, right. So that, again, another very important thing that Dr. Kabir is saying, that if once you've been told that you need surgery, the longer that time you take to think about it, to actually get it done, that is damaging you as well.
Yeah.
So that is very
But
important.
it has to be like, it's a very individualized thing. You have to have failed all conservative measures. before you undergo surgery.
Right, right, okay. So then you were telling us about the new techniques as well for spinal surgery. What are those ones?
Yeah, so I mentioned that actually. So new techniques are doing surgery minimally invasive essentially, which does include one of the commonest things that we do, like there's a lot of trauma in Pakistan, obviously, road accidents, motorbike accidents, spinal fractures. And that is fixing spinal fractures via minimally invasive technique is basically without making a long cut, you fix a fracture. And then similarly doing back surgery, disc surgery, sciatic surgery through a smaller incision and so that they can improve better. So this is one of the ways that you do back surgery. There are many other aspects to it, but I think that will go beyond the program's whole thing.
Right.
How you do MIS, we call it, minimally invasive spinal surgery.
Right, okay.
But that's all available essentially.
The expertise is there
Expertise is
for
there.
people to use.
Used.
Okay. We were talking about brain tumours. What exactly, living in Pakistan now, you've just come back from England where you were practicing, you had your training and everything. The incidence of brain tumour here in Pakistan as compared to over there, what difference are you finding?
So I think in Pakistan there are two differences that I would say. One, there is late presentation, okay? And when you go with the incidences would be the same because we're all human beings.
Right.
But I was seeing tumor more often there, the reason being because they get investigated early.
Okay.
Their presentation is early.
Right.
And obviously some people get over-investigated there as well. Everybody is getting an MRI, which is also not the right way forward.
Right.
For mild headache, you don't get the MRI scan. But here I think because of general fear and general maybe lack of understanding of the fact that if your headache is not settling, if you're feeling sick, your eyes are getting blurry, you need to see a doctor, you need to have a scan, an MRI scan, which is not, there is no radiation involved in it, it's a safe scan.
So if a person has a repeating headache or recurrence in headaches, they're feeling dizzy, they're feeling sick and blurred vision, they should see a neurologist first?
Yes, so neurology would be the first point of contact because as I said, I think we were discussing that before anyway, there are 1,001 causes of headaches and only one is the one that I deal with out of 1,001.
Right.
And that is a brain tumor.
Right, okay.
And that can present with a headache, that can present with a sudden collapse, that can present with a fit. And the general thing is to see a neurologist, and most likely neurologist would recommend the MRI scan if he thinks the headache is not settling with any medication.
Okay.
Or if the headache, because headaches types are different. And then once they are diagnosed with something, then they do tend to be referred on to neurosurgeon.
Right, so the diagnosis occurs via the MRI?
Diagnosis occurs via an MRI. There's no other way because this is the way we are going. We can't diagnose just by looking in.
Okay, right, of course. Okay, so of course, how do children present with brain tumors?
Yeah, so the tumors are slightly different as well, but children can present with various, like delayed milestones, for example. They're not walking, their head is getting bigger, they're not eating, drinking, they are vomiting, their balance is off. And children is a big age group, I mean it's up to 16, so I'm talking about small kids from birth to 1 year, their head can be bigger in size, they can't lift their head or they develop this their head becomes quite tense because their bones are not fused together. And they can, with the brain tumors in kids, they can also present with increasing water buildup in the brain as well. So these are things that mums notice and they tend to bring them, and then their diagnosis is slightly quicker as compared to adults, but still it's slightly delayed as compared to other countries where I was working. Right,
okay. So what treatment, I mean, based on the diagnosis of every individual will be, of course, different. What then treatment plan is followed?
So if it's a tumor, depending on if you've confirmed that it's a tumor needs surgery.
Okay.
There's no other way around it.
You can't do anything. You can't take medications for
Yeah,
it.
you can't
have
take,
to have
yeah.
the surgery.
So yeah, I've seen I've been practicing here for a little while now. It's not that long, but in the short time that I've been here, I noticed the presentation is very late.
You keep saying that presentation.
Yeah, presentation
is
is very late.
because people are ignoring their symptoms. What
Well,
are they doing?
It's not that they are ignoring the symptom. It's I think they're not clear. Even if somebody tells them, they're not like.
Denial?
There is probably some denial involved there as well, and
There's also a fear, I would think.
denial, fear, and maybe lack of trust.
Yeah.
And they present late. So if you have a brain tumor and you've been told you've got a brain tumor,
You have to have it looked
it depends on the type. There are benign tumors as well, which I keep an eye on, for example.
Okay.
So if it's a tumor, small tumor, benign tumor, I can see on MR that it's a benign tumor, then I'll keep an eye on you. If it doesn't need removal, I'll tell you that.
Okay.
But if it's a tumor that is a malignant tumor, then you have to have surgery done sooner. Your outcome is going to be better.
And as you said, we were discussing this before the program, you said that it's key to have, when you're diagnosed, to have that surgery if you need it.
Yeah.
You have to get it done as quickly as possible.
Yeah, because if you present late, I mean, as a neurosurgeon, I can do everything, but I cannot give you a new brain.
True.
Once that part of the brain is damaged, it's too late.
So, as Dr. Akbar told us, once a person is diagnosed with a brain tumour and the neurosurgeon has seen and they have recommended surgery, that's something that you don't want to wait upon because medications are not going to help and the surgery is very important. So the minimally invasive surgery then on a brain tumour, what's that, as you explained?
So minimally invasive, so if I operate, for example, I didn't bring any images with me, I should have. But minimally invasive, like for example, if you have a tumor, you're losing vision, okay, and you're going blind, and you've got a tumor just right behind the eyes where the nerves of the eyes are. So I operate on this tumor through the nose, okay, through an endoscope, which I mentioned again. It's like smaller than this pen, and you don't get a cut on your head or anything.
Right.
I don't have to do anything.
There's
I just
no
go through the
incision.
back of the nose. Sounds very easy, but I take the tumor
Sure
out,
it isn't.
and you get better. If you have a tumor up here somewhere, tumor can be anywhere in the brain. It's a big area, okay? If I can access it through the nose, I can go through the nose. If I have to go from the top, you have to make a smaller cut, and for that you need neuronavigation, which is like a brain GPS tool to find where the tumor is. And then I can go through it and operate through there. And depending on the type of tumor, I can put the endoscope into the brain from there as well.
Right.
And then take the tumor out in a different fashion. There are various ways you can use. There are various applications of how you can operate. You can use a microscope as well, but with minimally invasive, you need the neuronavigation is a key to brain GPS, because otherwise you end up making a cut which is quite big.
Okay. Sort of like the Google Maps that we use.
Well, not the Google Maps that we use, because I think it took me somewhere else the other day. It's much more advanced than that. Yeah.
We'll come back to the programme. We're having a fascinating conversation, but right now we're going for a break. Don't change the channel. Hello, welcome back to the programme. Well, we're talking about minimally invasive neurosurgery, and for that we have our expert with us, Dr. Akbar Ali Khan. Dr. Akbar, we were talking about the different types of brain tumours and what treatment is available for them. You're also telling us about the minimally invasive surgery that you perform. What about after the surgery, recovery, and how much of brain function does a patient get back?
Yes, so depending on the type of tumor, and brain tumor, certainly everybody gets scared when you tell them brain tumor, but there are different types of brain tumor.
It's a terrifying diagnosis.
But my job is, as a neurosurgeon, to, as I said, it's a broad spectrum.
Right.
There are benign tumors, and there are malignant tumors.
Right.
Okay? And if I tell you that it's a benign tumor, I'll try and reassure you that this is a benign tumor, don't worry. It looks benign, looks small. I don't think I need to do anything. I don't think I need to do surgery. And most likely I'll recommend a scan in like 3 months to begin with, then 6 months, then a year. And I'll keep an eye on it to see if it's getting bigger or not.
Keeping it under observation.
And I'll try and reassure you at that time. It's obviously a terrifying diagnosis, even a benign tumor, but I'll reassure you as much as I can.
Right.
But then it needs surveillance. It doesn't mean that if I ask you to come back in 3 months for a scan, you turn up 3 years down the line and you've already deteriorated to a certain degree.
That is so important.
So you need to listen to advice.
Of course.
Because health is wealth.
Yeah, exactly. As we keep trying to tell everybody.
Not wealth is health.
It's so true, absolutely. I mean, no amount of money can bring you back your health. It can't buy it back.
And I have seen that. Delayed, as I said, again, I'm saying that. Delayed presentation. I've seen a tumor, a benign tumor, presenting so late that the patient is blind.
Oh,
now, I can't fix your eyes anymore now.
Yeah.
It's too late. Even if I operate, they might come back, but you may not be the same again.
True.
So if I tell you to follow that up with a scan, follow that up with a scan. Me or any neurosurgeon, what I'm talking about. But then there are tumors that fall in between, and they are a size that you want to take them out early before they put pressure on the brain and damage the brain.
Right.
And I tend to take time with my patient and explain to them the scenario. It's very important.
Yes.
And then that needs to come out as well, because if I'm not sure that this is completely benign, it's slightly of a bigger size, that it's close to a brain area that if it gets damaged, then you'll have a problem. Then it needs to come out as well. And then there are tumors which grow very fast, which are cancers, brain cancers. We don't use the word cancer as such in brain, but grade 4 tumors we call them.
Okay.
And
the
those
very
are
aggressive ones.
very aggressive ones. So they need to be operated depending on their location where they are as soon.
Immediately.
Well, immediately means like within a few weeks of diagnosis.
Okay.
It doesn't need to be like the same night. But so the patient can have absorb the information and then come back and discuss with me and have the surgery done. They do tend to go for, like in Pakistan, I see that they'll have one opinion, then they'll go around and shop around, and which is okay. I mean, I think it's the way it is. They can multiple opinions and whatever, but the idea is to still get the surgery done sooner before it starts damaging the rest of the brain, because those kind of tumors, they need radiotherapy, chemotherapy as well, and that needs to be started after 3-4 weeks of surgery to stop it from growing. You know, these are malignant tumors. So if they've gone too far and damaged part of the brain, that, for example, you develop paralysis on the other side, you would not do very well in the long term. So we call it survival after a brain cancer.
Okay.
If you've gone downhill so much and you've delayed the tumor, your overall survival is affected. You know.
Quality of life and
not
everything.
quality, your survival even. Like you won't survive the treatment, or you may never get to the treatment.
Right.
So that is what I'm saying, is that the early treatment, early diagnosis as well, early treatment. And if you are in a good state, you'll survive the chemotherapy, radiotherapy, and your survival will be longer.
Right.
And I think if I could only pass this message through this program, which is the most important message, is we call it performance status, is a WHO criteria of performance status.
Okay.
And your overall survival from a brain cancer depends on what your performance status was at the time of surgery.
Ah, right.
So if you have a poor performance status, your survival was going to be, just a rough example, 5 years. If you have a poor performance status, your survival falls down to like 2 months, 3 months or something. So just imagine what the difference
so much
is.
of it, exactly.
So that is important. And I think that's what I'm working on.
And that's what you're emphasizing on again and again while we're having this program, is that the thing is that, you know, if you have been diagnosed, if your neurosurgeon has told you that you need surgery, this is not something that you can just sit about and and
People do go.
and hope that it will go away, because I mean, of course, you can understand.
People go to Hakims, trust me, I've seen that.
Again, I think, you know, the reason for that is the fear as well, because when you think about it, the brain surgery, you just think, oh, you know, how is that going to happen? But as you're describing, the minimally invasive procedure makes it so much easier.
That is minimally invasive. The risks are the same, minimally invasive or open surgery. The reality is, it's the recovery thing, and the generalized outcome is slightly different, but the risks are the same. So depending on whatever tickles your fancy, as they say in England, whoever you want to get the surgery done by, get it done sooner rather than later. It doesn't matter whichever way you go, but get it done sooner. If somebody wants, if you have a malignant tumor, the reality is.
Right. Are there any things that put you for risk at brain tumor, or is it just something that, you know, we don't know the cause why? Is it genetic? Is it lifestyle? Is it anything that a person can...
There are a lot of studies happening currently, especially when I was getting trained, even like the glioblastoma, which is the main cancer of the brain, is probably going to get reclassified. There are some variants, genetic changes in those tumors. Some patients respond well, some patients don't. But for the time being, I would say that we can never tell who's going to get
there are no sort of indicators that as to...
There are indicators, general indicators, but there's no such thing as genetic test that will tell you whether you're going to get a brain cancer
What
or not.
about lifestyle? Has that got anything to do with it?
I wouldn't know.
Do we find a
I don't
common
think so.
denominator anywhere?
No.
Okay, we get lots of myths that, you know, your mobile phone and signals coming from you know, gadgets can you know, give you a brain tumor.
Well, I haven't come across, so I'm more of a scientific person, so I haven't come across a recent publication, for example, in a good journal that will tell me that mobile phone can cause brain cancer. So I would say no is the answer.
Right, okay. So, you know, that will put a lot of people at rest because you get so many, it's a lot of information plus a lot of misinformation.
There is,
you know, really damages people. Okay, a CyberKnife and a GammaKnife, what exactly are those?
Yeah, so these are the tools, different tools that we use to treat brain tumors, for example. I'm going to talk about brain and spine, okay? So CyberKnife is a different form of radiation, GammaKnife is a different form of radiation. So where I was getting trained, we had a GammaKnife in our hospital, and we were using that. And the difference is different type of radiation. CyberKnife can be used on the spine as well, while GammaKnife is only for brain.
Right.
And they are available in Pakistan at present. And if they're not like the first modality of treatment for anything, except a few certain indications, but I tend to use it for if I've operated on a tumor close to a very important part of a brain,
right.
Especially the eyes and all that, and I've left a bit of tumor. So they are very focused, very precise radiation to that bit of tumor, so that it does not affect the normal brain.
Right, we'll get back to that question right now. We have to go for a break, but don't change the channel. Hello, welcome back to the program. We're talking about minimally invasive neurosurgery. And before we went to the break, Dr. Akbar, we were talking about the CyberKnife and the GammaKnife. Can you please?
Yes, so I think I wanted to elaborate on this, especially the GammaKnife, because GammaKnife is essentially a neurosurgical tool.
Okay.
It's used by a neurosurgeon.
Right.
So it's a completely different thing.
Right.
And I mean, Pakistan is a big country. Its population is probably, it's definitely bigger than Britain. And sad to say that we've got only one GammaKnife in the whole country.
Oh.
And that's in Karachi.
Right.
And it's good that we have one at least.
Yeah, true.
But patients from all over Pakistan have to travel down south to Karachi to get the treatment done, either CyberKnife or GammaKnife. And I think this is one of my kind of dreams. Obviously, it's a bit early. I've come here recently, and I think this is one of the things that I will be working towards in due course over the years, would be to have a GammaKnife in Islamabad.
Right.
So because it is the treatment that it offers as a neurosurgeon, I can we can provide that whole treatment in one go here, rather than patients traveling halfway
all the way to Karachi.
all the way to Karachi, which is
Right.
not good for the patient. And essentially, Pakistan, as our president recently mentioned in his address, Naya Pakistan, probably we need a new GammaKnife as well.
Right, definitely, of course. Okay, tell us about awake brain surgery. What does that involve? I mean, the concept, when you think about it, awake brain surgery, it just seems rather, frightening. I don't know.
Yeah.
What does it involve?
So awake brain surgery is one other tool in the repertoire of a neurosurgeon. And when you're operating on a part of a brain which involves speech, or where there is a higher risk of paralysis, then you tend to operate on those tumors while the patient is awake. And it's not that you can operate on every patient awake.
Of course.
It's only very selected cases. And then you have to look at the patient as well in a general, because having brain surgery is itself people are quite scared of that.
Yeah, and
but on top of that, to offer them awake, you have to educate the patient thoroughly before that. And I think awake surgery is currently happening. But I think patient selection is the key in that.
I see.
And patient education.
Right.
And I think if I'm to offer awake surgery to a patient, I think I'll have to spend a lot of time to explain to them the reason and the anxieties. And I think there's a very big role of anesthetist in this as well. It's not just a neurosurgeon, because it's not awake surgery, it's sleep-awake sleep surgery.
Sleep, awake, sleep. So you're sort of moving towards them asleep, then awake, then
sleep.
So
you do part of the surgery while the patient is asleep. Then the anesthetist, so anesthetist is very important in awake surgery. So it's not just neurosurgeon, it's a whole team. And then the patient wakes up, and then you do the surgery around that part of the brain, which is very important. And that is not to harm the speech or the paralysis or the other side of the body.
Right, so that's why you need them to be awake, so that you can
that
judge
you
how
can
they are
judge
responding.
how they are. And then once everything is done, then they can be put to sleep as well at the same time. So it's kind of like a cycle. It's not just that you will be awake and just having surgery.
A very intricate process then.
It's a very intricate process, and but if you operate on the brain day in, day out, this is what you do.
Right, absolutely. Is this being offered in Pakistan? Do we have awake
This
surgery?
is currently being offered in Pakistan, yes. I haven't done it myself since I've been in Pakistan here. But it's all about patient selection and the way you go around it.
Right, as you said, a very sort of calm personality would be key to...
Yeah, it's like when you offer, if you have neuronavigation, sometimes you don't need to do every patient awake as well, depending on the modalities that are available. So it can go a bit like if you have a hammer and you find everything looks like a nail to you, and just keep on hammering. So there are different modalities available. For example, we've got a new MR installed, which is probably like one of the few MRI machines available in the whole Pakistan. You can do functional MRI on a patient as well. You can map on a image where the speech area is.
Okay.
where the motor area is, or which controls the other side of the body. And then
Right.
you can use these different technologies as well, so that not every patient needs to be done awake.
Right, okay. Because we're running out of time, so just briefly one more question before we have to wrap up the program. The difference between a brain hemorrhage and a stroke, are they the same thing or not, then what?
So a stroke is kind of a fallage, they call it, okay? And it's like a layman's term for everything.
Okay.
That goes wrong with the brain.
Okay.
But there are different types of strokes. So a brain hemorrhage can lead to a stroke, or if a blood supply to a part of brain has been blocked by especially in those people who have raised cholesterol, smokers, high blood pressure, diabetic, these patients, they can have a stroke where the blood supply to part of a brain is stopped. And that leads to
A blockage.
blockage of blood supply, and that part of brain dies.
Okay.
And that's also a stroke. And then there is a hemorrhage either into that stroke, or there can be a different hemorrhage, which is from brain aneurysms, for example.
What's an aneurysm?
So aneurysm essentially is a weakness of a blood vessel around the brain that can rupture, which is a life-threatening condition.
Okay.
So all these things can fall under a stroke, but there are different types of them. And as a neurosurgeon specifically, we deal with all of these three, we get involved. But essentially, if it's a stroke, I tend to involve neurologists, because there are stroke neurologists, specific neurologists, which are stroke neurologists who get involved. And then it's kind of a combined decision that when we need to operate on these patients.
Right.
But if it comes to the aneurysms, which I mentioned, that's a completely different condition. That's also life-threatening. They tend to be managed by a neurosurgeon straight away, or a neurointerventionist.
A neurointerventionist.
Which is a separate person. He's a radiologist trained to
Interventional
minimally
radiologist.
invasive treat the aneurysms through the groin. It's essentially like a different treatment. And most of the aneurysms tend to be managed by that treatment option, because it's minimally invasive for the patient.
Okay.
But as a surgeon, if I have aneurysms, is not something you can do minimally invasive. You have to do it open.
Okay.
But there are.
What are the symptoms of a stroke or a brain hemorrhage?
Yeah, so as I said about the brain aneurysm can present with as if sudden onset severe headache, as if you've been hit on the head with a bat or something.
Okay.
And that's a classic presentation. Some patients collapse,
Right.
and that headache is not settling. It's a very severe headache. They present with that. Stroke, you can present with sudden onset of weakness on one side, which can be due to a hemorrhage or stoppage of blood to part of the brain. And if you develop weakness on one side and headache, that's also a presenting sign.
Okay.
So, as I said, in neurosurgery, I would like to say a few things, that in neurosurgery, what I mentioned, any neurological problem, the sooner you present to ER or a hospital, the better your outcome will be. And
Which
the
is
longer
key.
which is the main thing for this whole thing.
Okay.
And the later you present, and the later you avoid anything, or you're scared of it,
You're just making
things worse essentially for yourself.
Absolutely. Dr. Akbar Ali Khan, thank you so much for being on today's show. We definitely have learnt so much from your expertise.
Many thanks.
Okay, and with that we come to the end of today's program. I mean, I certainly learnt so much. And at the end, it's again about being mindful about your health, mindful about your symptoms, and to not take everything, in a sort of a careless attitude. It is very, very important to know what is wrong and what are the signs, and when you need to see a doctor or a specialist, and who is the right doctor you need to see. So until next week, stay happy, stay healthy. Bye-bye.